Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this dermatology series. And today we're tackling a serious dermatologic emergency, Stevens-Johnson syndrome and toxic epidermal necrolysis, often referred to as SJS and 10 spectrum. These conditions are rare but critical to recognize due to their high mortality and significant complications. Let's discuss what you need to know from a primary care standpoint so you can identify, manage, and refer these patients appropriately. Let's first talk about the pathophysiology and etiology. SJS and 10 exist on a spectrum of mucocutaneous reactions characterized by widespread epidermal necrosis and detachment. They are most often triggered by medications including antibiotics like sulfonamides, anti-epileptic drugs, allopurinol, and NSAIDs. Infections, particularly Mycoplasma pneumoniae, can also play a role in a smaller percentage of patients. The classification of SJS in 10 is based on the percentage of body surface area affected. If less than 10% body surface area affected, it is called SJS. If it is 10 to 30% of body surface area affected, it is considered an overlap of SJS and 10. And if greater than 30% body surface area, then it is called 10, toxic epidermal necrolysis. Patients often present with a prodrome of fever and influenza-like symptoms 1 to 3 days before the development of mucocutaneous and skin lesions. Early signs are ill-defined, coalescing, erythematous macules with atypical target lesions. These progress to vesicles and bullae, and within days, the skin begins to slough. Mucosal involvement occurs in 90% of cases and can be oral, ocular, and anogenital. Something important to look out for is when there is ocular involvement, which can lead to long-term ocular sequelae. Diagnosis is primarily clinical, supported by the patient's history and physical exam findings. Skin biopsy can confirm the epidermal necrosis, and tools like the score of toxic epidermal necrolysis, abbreviated as score 10, can be helpful to assess prognosis and guide appropriate management. The cornerstone of SJS and 10 spectrum management is early recognition and immediate withdrawal of the causative agent. In addition, supportive care, which includes wound care, fluid and electrolyte management, nutritional support, temperature management, pain control, prevention and treatment of infections, ocular care, and organ support are also needed. Patients with significant body surface area involvement should be managed in specialized centers, such as specialized dermatology units, burn centers, or intensive care units. And beyond this, cyclosporin is suggested rather than other systemic adjunctive therapies for these particular patients. Next, let's talk about prevention and education. Patients who survive SJS and 10 attributed to a medication must be educated about future avoidance of the causative drug and other chemically related agents, and understand that re-exposure may be fatal. Relevant information should be inscribed on a medical information bracelet or necklace and worn at all times. Electronic medical records, allergy cards, and alerts should always be updated accordingly. All right, let's test ourselves with some questions. Question 1. A 45-year-old woman presents with a 2-day history of fever and a painful, rapidly spreading rash. Examination reveals extensive epidermal detachment involving 15% of her body surface area, oral erosions, and conjunctival injection. She started trimethoprim sulfamethoxazole 10 days ago. What is the most appropriate next step? Is it A, high-dose systemic corticosteroids? B, discontinue the causative medication and initiate supportive care? C, prescribe oral antibiotics to prevent infection? Or D, apply topical corticosteroids? I'll give you a couple of seconds. If you chose B, discontinue the causative medication and initiate supportive care, you are correct. Immediate withdrawal of the causative agent and initiation of supportive care are the mainstays of treatment for SJS and 10, and referral to a specialized care center is critical. Question 2. A 62-year-old man with a history of gout presents with a diffuse erythematous rash that began 7 days after starting allopurinol. Examination reveals about 8% epidermal detachment. Which of the following is the most likely diagnosis? Is it A, erythema multiforme, B, fixed drug eruption, C, SJS, or D, exanthematous drug eruption? If you chose C, SJS, you are correct. The most likely diagnosis is SJS due to the patient's presentation of epidermal detachment associated with starting a medication like allopurinol. Great job! That wraps up our discussion on Stevens-Johnson syndrome and toxic epidermal necrolysis. These conditions may be rare, but recognizing them early and taking swift action can make all the difference in patient outcomes. Remember to always assess a detailed medication history and keep those high-risk drugs in mind during your evaluations. If you found this episode helpful, don't forget to hit subscribe and turn on notifications so you never miss an episode of the ProPA podcast. Stay tuned for more high-yield content designed to help you succeed in clinical practice and on your PANCE journey. As always, this is the ProPA podcast, where future pros in medicine are made. See you next time.